So it's my pleasure. I'm Mary Louise McLaws and I'm the Health Water Lead for the Global Water Institute. So it's my pleasure to be part of the Global Water Institute and to have the Global Water Institute host Dr. Jake O'Brien, who is a really important collaborator on studies at the University of New South Wales. He's going to be talking to us today about how we use wastewater epidemiology to look at the spatial and temporal relationships with biomarkers. We are particularly interested in antibiotics, but Jake is going to tell you about interesting lifestyle biomarkers, and lunch should be here soon, so I'm sure you wouldn't mind people getting some lunch. Sadly, I forgot to bring alcohol. Beth Hadrod is your health leader, so apologies for that. So thank you very much, Jake.
Thank you, Mary Louise, and we can have this as informal as you like. If there's something on the slide you don't quite understand, just stick your hand up or yell out at me. I'm not going to be offended. So as you can see, I come from the Queensland Alliance for Environmental Health Sciences, which is located at the University of Queensland. And specifically I'm going to be talking to you about drugs in sewers, how measuring biomarkers, specifically for legal and illicit drugs in sewers, can reveal population consumption habits, and how this approach can be applied to antimicrobial resistance surveillance. So, no questions yet. Okay, so here we have the origin of wastewater-based epidemiology. So basically it was about the late 1800s that we actually saw the first wastewater treatment plant built. And it was the first one was either in the UK or the US. It's a bit of a debate. I think this slide suggests it was in the US. Oh, thank you. Let's see if that works. And then in the late 1990s, somebody you might recognise from UNSW was a PhD student at the time, and he and one of the most famous drug epidemiologists in the world, Wayne Hall, put in a grant proposal to actually study illicit drug usage through measuring drug biomarkers in wastewater. And as far as I know, Stuart Kahn was the first person to ever actually find illicit drugs in wastewater. So that's why he gets to be in the cartoon. So what can wastewater data tell us? So obviously, as you've already seen, illegal use of drugs such as methamphetamine, MDMA, cocaine, and it provides an avenue of investigation. So we're talking about real data. And it also gives us something that we can measure the effect of interventions. So back when we started, this was about 2009, so before this we had been working on recycled water and trying to work out how to measure chemicals as they entered advanced wastewater treatment plants and came out the other end. But we had a little problem in Queensland that it rained and we didn't need these recycled plants anymore. And so that's when we jumped on the bandwagon of what was emerging since about 2005 of trying to measure illicit drug consumption via wastewater analysis. And this actually was Funyan Lai's PhD project. So she did her PhD with us from about 2009 to 2013. And this was our very first ever set of samples that we got. And this was just for a 2-week period that we got samples. And the important thing here, by measuring just a few illicit drugs, we can actually see some differences in terms of consumption. I think I've not actually put up what they are, but basically for some illicit drugs you have this flat line throughout the week. So things like cocaine used on the weekends, whereas methamphetamine seems to be used consistently throughout the week. So what else can it tell us? Well, we can use it to make these spatial comparisons. So this is the most recent data that's come out of the National Wastewater Drug Monitoring Program, which I'll tell you a little bit more about later. I've used cocaine as my example here because if you see this point here, We're talking about Sydney, and you're winning. Congratulations, you use the most cocaine. You can also see down the bottom here, I've got this one graph. This is nicotine consumption, and it's a little bit hard to see, but what we've actually found from between 2010 and 2017, we find that there's actually a decrease in nicotine consumption. So this is really nice. This involved about 300 data points of wastewater before we could actually pull out a significant trend. But it tells you the importance of doing things over a longer period of time. And the key message here is about archiving your samples, because back in 2010 when we first started collecting these samples, we did not have a method for actually measuring nicotine and its metabolites within wastewater. So the things that we know we can look for in wastewater include illicit drugs, pharmaceuticals, alcohol, nicotine, disease and diet, biomarkers, as well as industrial and biological materials. So as I was saying before, that we can use this for time trends. So our colleagues at the University of South Australia also began their research about the same time as we did in 2009. And when we get really nice long data sets, we can do these really nice time trends. And you can see here that we basically have this 5-fold increase of methamphetamine consumption. Well, actually, it's more than that. It's 5-fold between 2009 and 2016, and it's even up higher in October 2017. So this is an example for Adelaide. But this is the important thing here, is that we're looking at this work, and we're currently funded through the Australian Criminal Intelligence Commission. What are they interested in? The impact of big seizures. They're not so interested in the little guy who's consuming, because that's a lot of work to do something about that. They're interested about these big seizures. And so whether or not this was entirely driven by a big drug bust, we can't tell you, but there's at least some evidence to show that big seizures can have impact. And the interesting part here is that you actually see that this was seized off Melbourne, and this is consumption in Adelaide. And over here you see that this seizure was off the Western Australia coast, and we see a drop here. What it also tells us is that people still find a way to get their methamphetamine. So we can seize as much as we want, but if people want substances, they can still get them. So, what else can wastewater tell us? It can inform on disease. So biomarkers or drugs which are proxies for disease. We're reasonably confident with this. So there's endogenous markers such as histamine, so allergies, so I get hay fever. A marker of histamine I think we measure is MIAA. But then you can also look for exogenous, so salbutamol for asthma or antibiotics. And we also can look for marks of oxidative stress, and there's some papers on that. We can also look at the frequency, so we can at least easily adjust our frequency. So we can collect samples daily if the water authorities are nice enough to allow us and are happy to collect the samples, or we could do it once per year. And as I said before, we can do retrospective analysis depending on sample archival. And often we can do this with a short time lag, so I can take a sample today and have the measurement in the afternoon. And this can be a cost-effective way to answer big picture questions. And in terms of remote locations, at least for illicit drug consumption, there's not a lot of other data out there. So this gives us a tool that we can find out what's happening in these places. So this was a paper that we published last year in PNAS. We're very excited by this because we've been collecting the catchment maps of all of the wastewater treatment plant catchments. And specifically, we've been collecting samples during Census Week. Put your hand up if you know what census is. So it's a week where on one specific day, it's Tuesday the 9th of August in 2016, it'll probably be about that next year, when we have the next census. where you fill out a survey about yourself. How much income you have, what's your education level, and a whole heap of other parameters. And by doing this from all around the country against all, and mapping the census data to the wastewater catchment maps, we can produce graphs that look like this. So here we can see that amphetamine and methamphetamine consumption correlates with poorer, younger people. Older people, surprise, surprise, need more heart medication. So it seems to make sense. What about the rich people? Apparently rich people consume higher fibre diets, more caffeine, and ethyl sulfate, which is a marker of alcohol consumption. So it's probably not the poor young bogans who are drinking as much as you think they are. Other things that we can actually do with this is we can pull out socio-demographic data. So here we've got just some markers of tramadol's an opioid painkiller, and there's correlation between your skill level. So if you're a highly skilled person, you're probably doing less labour-intensive work, more thinking power, you don't need as much tramadol, whereas we see a correlation between labour, so manual labour, and opioid use, at least in terms of tramadol, and that's just one example. So in terms of our big national wastewater drug monitoring program, this was a program that started in 2016 as a 3-year program, which has now been continued for another 4 years. And the aim of this study is to do spatial and temporal comparisons at 50 locations across Australia and up to 6 weeks per year. And we deliver 3 reports per year. The most recent one came out on Monday. So that's report number 9. And in that we're looking at 8 illicit drugs, fentanyl, oxycodone, nicotine and alcohol. And you can see that in this program we cover all of the capital cities in Australia, as well as some regional places in each state and territory. And this is our latest snapshot of methamphetamine consumption across Australia. You can see here that we had to find an easy way for the public to understand a graph, so you just get box plots. There's no whiskers, there's no uncertainties, we just have the minimum, the maximum and the mean. And we don't identify any of the catchments. And what we can see across here is this red line is the regional average. The blue dotted line is the capital city average. This is across all of Australia. And then the black solid line, that's the combined average of capital and regional. And you can see that some places have higher meth consumption than other places. So, but can't tell you which catchment is which. But the individual treatment plants, they get their own data back. If we change across to the party drug MDMA, we see a different picture. And then if we go across to Sydney's favourite chemical, we see cocaine dust. And in other places, there's just basically no cocaine consumption.
Interesting, not a lot of cocaine consumption, Ken.
Yeah, so one thing I really want to do is sitting week versus non-sitting week, specifically from Peter Dutton, but that's off the record. This is the latest New South Wales data. I thought I'd actually present it. So here we present the data as estimated consumption on doses per 1,000 people per day, just to give you an idea of the scale of usage. So, for example, methamphetamine is quite high, heroin usage quite low. Why is cannabis not up there? The simple answer to this is we do not have dose data. Cannabis and excretion data is not particularly great. But it's something that we're working on. It's not that we're trying to hide cannabis usage, it's just that we don't have these things. So, what wastewater data can't tell us is about individual behaviour profiles. So, what form the drug was consumed in. I put a little star on this one because in some cases we do have pyrolysis products. So smoking of methamphetamine, we've published on that. Co-consumption, put another star on that one because for cocaine you can actually tell whether or not it was consumed with alcohol because there's one specific marker, cocaethylene, which is from the co-consumption. But we can't tell about poly drug use. Price, definitely can't tell that from the wastewater. Purity, dose frequency, misuse frequency, all of these other things. We can't do that, but that's okay because surveys have a purpose too, and they can help provide us information on that. What else can't wastewater data tell us is underlying reasons for why use is changing, because it could either be one or multiple factors. So the big drug seizures, for example, we're not entirely sure, but the evidence suggests that, at least for Adelaide, that had a big impact. For pharmaceuticals, we generally cannot distinguish between diverted and therapeutic use. Sometimes we are lucky where we might be able to pick up illicit use of a pharmaceutical because it's simply not available in Australia, or if it's been made in a different way to the accepted pharmaceutical use way, we might have this difference in the enantiomeric ratio or something like that. So this is the simplicity of wastewater-based epidemiology. Consume the chemical, go to the toilet, we sample the wastewater, or nice people sample the wastewater so that we don't have to, and then we measure the drug. But this is probably more reflective of the true picture, because we're not just getting samples from your specific toilet, we're getting samples from the whole community, and it contains all of these things. A very complex sewer network. We need to rely on flow meters that are at the treatment plants themselves. We need to get this data from the operators of the plants. We're also relying on good auto sampling techniques. We're also depending on how much volume we can get, even then how we preserve it, store it. That's a picture of Jochen Mueller in one of our freezers. We currently have 6 walk-in freezers and we're hoping to get another 10. But a lot of wastewater in our freezers, and then you've got sample prep, you've got the analysis, you've got all of these other things before you end up at how much was actually consumed. So, is it still simple? Depends on the question. So the principle of wastewater-based epidemiology for consumed water-soluble chemicals is this, that the load, the mass load is equal, normalised mass load to population is equal to the concentration in the sample times the flow of water for that day divided by the population size, and then corrected for excretion factors or degradation if we could somehow do that one day. So, put up your hand if you're an analytical chemist. Not many. Wastewater treatment plant operators? None. Sewer engineers? Well, I've got a couple, that's all right. Pharmacokineticists? Social scientists? Metabolomists? Population modelers? Researchers? I think we all should be that one. Epidemiologists? Public health officers? None. Policy advisors?
Maybe a half a hand.
Yeah, I think I'm a half hand for that one. Criminologists. So the simple fact of the matter is that we actually have to rely on data from other sources. So it's an extremely multidisciplinary science. So the first challenge that we actually have of getting wastewater samples is sampling. So for example, we've got this red line, which is the flow throughout the day. So for the concentration of a frequently discharged substance, we've got this wiggly line. That's quite nice. But what if you've got a chemical that only comes through once or twice a day? You see this here. how do we get that? We need to use what's called a flow proportional sampling mode that's continuous. And there's very few places in Australia that actually have this set up. I think we've been the only people to put it in, and it's prone to blockage. Otherwise, you can sample continuously, not flow proportionally, but then your concentrations aren't truly reflective of what's coming in. But the main thing that seems to happen in Australia is we just have this time proportional mode where you just take a sample every half an hour. Most places seem to be about an hour, and that's to meet compliance. And this is a scenario for water-soluble chemicals. Estimating population size is also a difficult one because the data that we've got from wastewater treatment plants about their population size versus the data that we get when we map the catchments to ADS data can be very different. Fortunately, we had an idea, well, I had an idea back in 2011, one day before census, that if we got samples from all around Australia and looked at high-use chemicals such as artificial sweeteners, paracetamol, caffeine, that hopefully the mass load of these reflects the population size, so the amount coming into a treatment plant per day reflects the population size. Fortunately, this held true for about 14 chemicals, and then using some fancy statistics, we can use these markers within wastewater to give us a daily number of people we feed into our samples. So what makes a good wastewater-based epidemiology marker? So firstly, excreted via urine in consistent amounts. Why do I say urine? Because we're best at sampling water-soluble chemicals. Secondly, it's got to be detectable in wastewater. Thirdly, stable in wastewater. And the fourth one is that it should have a unique source, as in human metabolism. So some chemicals we know they get metabolized further in the sewer. So we have to try to investigate these for all of the chemicals that we look for. And if we want to use them as population biomarkers, then we want these other two things, which are low variance in the per capita daily excretion and daily per capita excretion not affected by independent variables. So seasonality, for example, we know that affects the use of artificial sweeteners. The one I'm going to talk a little bit more for now is the stability issue. So Zaccato, one of the godfathers of this research, once said, the main aspects to be thoroughly validated involve the chemical and biological stability of the drug's main excretion products and its partition in sewage. So it's not new, this is 2005. So where has this really been happening? So a lot of people have been doing this one. They've got their collected wastewater sample and they investigate the stability in the wastewater. Mind you, this auto sampler has probably collected that wastewater over a 24-hour period at 4 degrees Celsius. So this is our simple experiment that we can do for this. And we do this for a range of chemicals. We're all happy because all of them have these nice little flat lines over a 12-hour period. So that looks fantastic. So we've got stable markers. Some of them just even aren't very good using this setup. We don't need to go through them individually, but here's an example. But if the stability isn't great, I can also investigate preservatives. So something we can add to that sample to keep the chemical intact. But this is what stability actually is. So how stable is that chemical from the point that it enters the sewer system into the point that we can analyse it. So we can only influence the stability from the collection point, but we can't influence stability in the sewer. So this is a fairly simple diagram to show you what we have throughout sewer catchments. We have these two things called a gravity sewer and a pressurised sewer. the difference is gravity sewer relies on gravity to move wastewater from point here to here. But through our catchments, we have these pumping stations or storage tanks, which then have to pump uphill. You might have heard that saying before. These are pressurised sewers, so we actually have different types of biofilms growing in these sewers, depending on how much air is in the sewers mainly. So we're really lucky. We have these little control reactors, gravity sewer reactors, and rising main reactors that we can investigate the stability of chemicals in. And this is through our connection with the Advanced Water Management Centre that we can do these things. And we can use them to look at the stability of our chemicals. So this is just an example of the ones I had before that all seem to look pretty stable based on our benchtop study. But as you can see here, the red lines are the rising main, green's control, and I think blue's the gravity sewer representation. You see that almost none of them are still stable for the whole 12-hour period. And same scenario here, where you've got some that just degrade really fast in actual sewer systems. So, our sewers are complex. There's different types and lengths of pipes, residence times, temperatures, pH, all of these things, and they all influence the stability of the chemicals in the sewers. We also have access to a pilot sewer in Brisbane that actually built through an ARC discovery, and this is actually a 1 kilometre long setup, and we have both a rising main and gravity sewer represented in this, but the issue with this is it's expensive to maintain, and it's not a small system. So if you want to investigate the stability of something, either it's got to already be in that sewage in decent enough concentration, or you're going to have to buy a lot of it. And just to show you some of the results that we get between the lab scale sewers and that big pilot sewer, they seem to be fairly representative, so that's encouraging. So we need to consider in-sewer stability to use wastewater-based epidemiology as my take-home message from that. So where is wastewater-based epidemiology for antimicrobial resistance? So there's the antimicrobial compounds themselves, and if we go through our tick list, we stop at the first one, that they're excreted via urine in consistent amounts, because for some chemicals, they don't go through the body. You put on triclosan or whatever as a hand wash. We can put a tick beside detectable in wastewater because we can see them in wastewater. Like a lot of the ones we look for, we can find them. We haven't yet looked at the stability for most of them, but that's something we're working on. And we also don't know if the parent compounds are being metabolized by bacteria in the sewer, which is highly possible. For antimicrobial resistance genes, again, I think we've got issues with this first one, that they're not excreted via urine in consistent amounts, so they may be stuck to the solids going through. How well do we sample that is anyone's guess at this stage, but I think it's something that we can investigate. We know they're detectable in wastewater because there's studies where people have found them, but again, we don't know the stability, and in some cases it could also be that the genes are coming from biofilms, bacteria existing in the sewers. So, where does my research institute fit into the antimicrobial resistance picture? So we have ultra-trace tools for measuring small organic molecules, including antimicrobial compounds and their metabolites in wastewater. So we can use these targeted approach where we can see extremely low concentrations of these things. Or we can use these suspect and non-target analyses where if chemicals are in higher concentration, we can pick up the hopefully pick up the ionisable unknowns, put a disclaimer on it being ionisable, just because Stuart's in the room. And we can also investigate the fate of these chemicals. And it's mainly going to be in these sewer reactor setups, because I think this is probably out of the picture. I don't know if we'll be able to continue to fund this one anymore anyway. So I've got 3 take-home messages. The first one, wastewater-based epidemiology is a useful tool for monitoring chemicals used by populations. This is demonstrated throughout the world, where it's extremely useful for seeing what's happening in terms of illicit drugs. It's suitable wastewater-based epidemiology markers must meet a range of criteria. And thirdly, while wastewater-based epidemiology shows promise for antimicrobial use and antimicrobial resistant surveillance, further research is required to determine its suitability. So I think that's where we'll be working hopefully the next few years on. And I'm only one person in quite a very big team, so these aren't all my ideas. Occasionally there's one comes up, but this is my team. We share the ideas, we share the papers. So thank you for coming along. And if anyone's interested in the drug monitoring reports, there's a link, or you just Google ACIC, the Australian Criminal Intelligence Commission, and it's the first thing on their website almost all the time is these drug reports, because people seem to like them. Thank you.
Thank you very much.